So first up, would like to invite Professor Rohit Shetty. Rohit, as all of you know, has done some seminal work in the area of keratoconus over the last decade and has also published a lot in the early diagnosis as well as detection of keratoconus. So Rohit, the stage is yours. Thank you very much.
Thank you, Praveen, and it's wonderful to be part of this IC again. Uh, the talk is on newer diagnostic modalities in keratoconus. These are my financial interests. I'm sure it's not going to affect what I'm going to speak in this session today. Uh, all the diagnosis of keratoconus relied heavily on indices. It, many indices have been compared head on with the others. Unfortunately, we can never compare one company's indices with the other because the way it's designed is completely different. The question always comes is, are they adequate for diagnosis of early keratoconus? So when you look at the diagnosis, anatomically, you look from the epithelium, the stroma, the biomechanics, imaging, and also things which are beyond just imaging perspective, the biomarkers, some of which may have relation to what Dr. Namrata just mentioned today. The epithelium is known to be one of the earliest changes of in keratoconus, and the work done by Artemis by Dan Reinstein in a very early stage spoke a lot about how the epithelium changes can have a huge impact in understanding the keratoconus even before the stroma has started changing. Over time, we have machines like Cassia 2, the MS39, uh, RTView. Many companies of ASOCTs have now or have built in their epithelial maps or in the process of building one. But what's interesting for me from an epithelial point of view is just not the early detection. It's about impact of epithelium on your on the optics of your eye, including your cylindrical component or also the higher order aberrations. MS39 is a smart tool. It gives you the cylindrical component arising from your epithelium. It also gives you the coma and other aberrations arising from your epithelium. So if you are trying to treat anything on on your cornea, you have to factor this in because many times epithelium itself could be a major factor for coma, and that's what you're discarding or taking it off. And you may be treating what you have it on the cornea, on the epithelium, you may be actually treating on the cornea. So these factors were never considered in the previous laser based systems. And you can see the difference between these two with a significant amount of coma just from your epithelium. This is very important as far as keratoconus is concerned. It helps in suspicious cases. Early coma changes might help in detecting it's from the epithelium. And when we look at what really makes this epithelium changes, then you go next layer would be the corneal nerves. The corneal nerves have different functions. They maintain the hemostasis of your eye, epithelium, and other functions. You have a lot of these patients have multiple changes on your nerves. One, they may have less density of your nerves. They may be filled with dendritic cells, which are signs of ongoing small inflammations. Many of them have very insignificant microneuromas out there, terminal bulbs on your corneal nerves. Without understanding all this, let's assume that you treat these patients with, say, cross-linking. Your outcomes of cross-linking completely differs. The reason being, all these factors here have a huge implication in wound healing, and each of these factors have an impact on how the corneal stroma heals to a particular insult. And these are filled with different types of molecules, some of which what Namrata ma'am had just discussed. And this is what you end up with: severe amount of scarring, severe amount of excessive flattening, severe amount of things which are beyond your control. So understanding the hidden mechanism in the corneal nerves and all these related structures are very important in looking at the outcomes of your cornea. The stroma imaging started getting a lot of interest again after MS39 came into the picture. It's just a software driven. It what it does, it just takes out virtually the epithelium and then gives you the elevation of your stroma. For example, without the epithelium, this is your how much you see elevation. This is a true elevation because many times the epithelium will mask the whole structures. And you can look at it from a surgical outcomes. You can look at what is happening at, especially in keratoconus. If you look at it from a progression, your real progression is from the stroma, and you can see that this keratoconus progression, how it's progressed. And sometimes you can have patients who are very stable. The epithelium might be changing. Epithelium is very dynamic. You treat the dryness, you treat the ocular surface, the epithelium might change, but the true stromal elevation does not change. And true stromal elevation could be a very important factor when you look at the corneal progression. For example, in this case, it's it's trying to flatten on the topographies, but you can see that the stroma seems to be perfectly the same. So flattening could be induced by an epithelial change itself, which your pentacam will probably not fit. And you can see that the 14, 13, these are the values which you see exactly in that zone. After the stroma comes the biomechanics. A lot of work has happened on biomechanical assessment on the corvus. Multiple parameters have come in. Uh, you have the DA ratio, integrated ratio, SART1, and CBI, TBI. But for me, SPA1 is one of the most important factors, especially to look at the corneal strength. Anything above 100 is considered normal strength because this is not heavily dependent on your corneal thickness, intraocular pressures, and multiple other hydration parameters. All the other things here are heavily dependent on your IOPs. If IOP is high, everything is falsely low or falsely high. The other thing which is not dependent on the IOP stress strain index, but Ahmed El Sheikh, where closer to 1 means it's stronger. And again, this is independent of corneal thickness. But when you look at biomechanics, you have to look at things which are independent of corneal hydration, thickness, and IOP, because otherwise everything gets affected by these things. Uh, the Brouillon is a very interesting concept which looking at the biomechanical modulus at different parts of the cornea. But I have never seen a more uh, uh, it's not moving here. It's not moving. Yeah, and this looks at different the biomechanic at the different places. We have this machine, but I have one of the very moody, whimsical machines I've ever used. 90% of the time, it doesn't work only. So we have no idea. I mean, this we got it for a joint grant. I really don't know what to do with it because the company gives keeps asking us to do multiple things. When it works, it gives you these kind of changes. But in theory, it's a great tool. But in practice, I don't think it's going to ever come into clinical use with this kind of a backing. We started working on collagen imaging from 2015 because we wanted to study the real factors which change in the keratoconus, because these are important factors. The collagen one, your lysyl oxidase, which hold them, because different corneas have different types of collagen, and your topography is not a factor to look at what is going to happen, what kind of collagen you have. It uses the polarization right. Birefringence is your principle. We collaborated with a few centers and we started building the first collagen imaging. And now it's standard of care in my clinic. Every single patient I do it within, it just takes 1.5 minutes per eye. And the report comes instantaneously, which we have generated. And you can see that the darker checker pattern looks healthier. The lighter blues, the turquoise blues, means the collagen properties have changed, and absolutely no dark blue means your property of orientation of collagen is completely lost. So we are with immediate effect, we're able to image the collagen, and instead of just looking at just the parameters and all the indices, you are actually looking at the true collagen what you have. And advantage is that you can look at it from a progression aspect of it. You can look at the Bowman's layer. This is your Bowman's thickness, epithelium. Every layer of cornea in keratoconus can be seen, and this is a stable keratoconus. And it's very interesting. This is your Bowman's, which is on 2021, and in 6 months you can see that the Bowman's is thinned out. So you can even map the way the Bowman's is thinning out, and Bowman's is just around 4-5 microns, around 2-3 pixels of it, but still this is a 1 micron resolution. So yeah, and you can see that the collagen changes. This is your collagen before, and collagen changes. So degradation of collagen can be picked up much earlier, and you can use this actually to study the outcome of your procedures also. uh, the biomarkers have a very important role, because when you look at these kind of cells, the cells which are functional and cells which are stress, which don't function as it should be, they secrete a lot of cytokines, and many of these cytokines are the ones which drives the diseases, and these things needs to be looked at and evaluated. So we developed our own biomarker kit from the tears, and we look at all the cytokines. And Dr. Namrata mentioned about the ICAM1. Our kit also is able to look at ICAM1. So you can decide if it's high. In this case, the liftigrast, what she said, may not work because there is no ICAM1 in this patient. So based on what is higher or lower, you can actually choose. And this is what we are working on. It's a very long process of choosing the drug based on what molecule you have. And you can see that this is where probably the liftigrast might work in your patient. But without knowing, just treating it for everybody may not be the right way to go. And these are all the papers which we published on how we can use the drug to titrate it to what is necessary in terms of progression. So understanding the epithelium is important. The stromal imaging, I think, is going to be the future. A combination of topography and biomechanics is great, but we need to refine it more. What I'm really betting on is understanding the collagen itself. And the most important thing which controls everything is the ocular immunology. Thank you, Praveen and team, for this opportunity.